mouse on the screen. There
Oh,
you
great.
go.
I got it. Do you see that little red dot
Yep.
there?
Yep.
Yeah.
Here. Okay.
Yep.
Okay. Perfect. So I'm just going to go. Stop me at any time with any questions. I don't see any. I don't see any like boxes that are showing me what questions there are. So if you see any, Juan or anybody else, just fire away at me and I'll stop what I'm doing. So these are, I think, some important things to understand about the anatomy. We're going to see a lot of the same stuff over and over and over again, different perspectives of it. But so we're basically talking about eustachian tube dysfunction. And as you can see here, so this is the outer ear. This is kind of what you're supposed to keep clean. This is what you get pierced. This is what you clean behind, and also funnels sound into the external auditory canal, which, as you see, is partially cartilaginous, partially bony. And then there's the eardrum here, and then there's the bones behind the eardrums called the malleus, incus, and stapes. There's three of them. And then this purple thing is the inner ear, which stimulates and sends the nerve signal back to the brain. That's Juan's territory. But the nerve leaves here and it goes to the brain, and then you sort of interpret it in the auditory sections of the brain. Now, what we're worried about is the eardrum, the middle ear, and the eustachian tube. As you can see, the eustachian tube is about 2/3 cartilaginous and 1/3 bony. And this is a picture of a child on your left, okay? And this is a picture of an adult on the right. The same structures, but they changed in size and angle and relationship to each other a little bit as we get older, which is why under normal circumstances, middle ear disease, eustachian tube dysfunction is much more prevalent in the young child than in the adult. And there's a number of reasons for that. And I'll touch on that as we're talking. But basically, the goal is to have relatively even pressure on the outside and the inside of the ear, or the middle ear space here. And the way we do that is by using the eustachian tube as a valve that opens and closes to regulate pressure in the middle ear space. So it's basically like a valve. And we want it to be about even with the outside world. When there's a lot of pressure from the outside, like when you're diving or when we're landing on an airplane or any other situation that may cause resorption of middle ear air, then you're going to get a relative negative pressure in the middle ear space, which will cause discomfort, may cause disorientation, which is obviously very dangerous while we're diving, as well as possible development of fluid in the middle ear and possible eventually perforation of the eardrum under certain circumstances. So our goal is to keep air going into the eustachian tube, entering the middle ear space as pressure is building up, pushing on the eardrum. And so that's why the pressure is getting, I think I misspoke, but the pressure gets greater as we descend, either on an airplane or into water. The water pushes on the eardrum and pushes it in, causing a relative negative pressure in the middle ear space, causing discomfort, causing possible trauma to the inner ear, which is that purple structure there, or what we call the labyrinth. Possibly can cause a tympanic membrane perforation, can cause also fluid development, make it very uncomfortable to further descend. And let's see what other, okay, let's go on and see what we have here. So here we see that the eustachian tube is sitting at the back of the nose here. And air travels from the back of the nose up the eustachian tube into the middle ear space. So in actuality, you can think of the middle ear and the eustachian tube as like a very highly specialized sinus cavity, just like the sinuses in our cheeks, in our foreheads, in between our eyes. And this is sort of a close-up picture of what I see when I look at the eustachian tube. endoscopically inside the nose. These are some pictures that I kind of got off the internet that I thought really demonstrated the anatomy well. And you can see there's an anterior, what we call anterior tori, posterior tori, and there's muscles that attach to that help spring them open. And those are when we do stuff like yawn and swallow, we're trying to stimulate those muscles to pull open the eustachian tube. Does anybody have any questions so far?
Hey, Jonathan,
Nope.
question. Jonathan,
Yes.
can you hear me?
Sure.
So
I can hear you perfectly.
one of the questions that came in from audience was what are the most common issues that you find that can affect this region, the region of the torus tubaris, the entrance of the Eustachian tube in young adults, for example?
In young adults? Okay. So the same issue. Okay, so let's sort of talk, let's go forward a little bit to some pictures I have here. Okay, so here's a good picture of the nose, okay? And as you can see, air enters the nasal cavity, the inferior turbinates filter the air somewhat, warm it up, humidify it, and then there is the nasopharynx. The nasopharynx is where, oh, there, I saw a lot of people just pop on. I gotta get this out of my way. There we go. So as you can see, so the nasopharynx is the opening where the opening to the eustachian tube orifice is. You see, here's the sphenoid sinus, here's the frontal sinus. Those are all openings that go into the nose. And this is in the nasopharynx, which is what our term for the area of the throat that's behind the nose is called the nasopharynx.
Mm-hmm.
So anything, and here is an endoscopic picture, a real endoscopic picture of what the eustachian tube looks like. This is the left eustachian tube. You enter that and you travel to the middle ear. That's where we want air to enter. Go back to we inhale air through the nose. It goes down the palate here and you swallow it not you swallow it, you inhale it into the lungs as it goes past from the nasopharynx into the oropharynx, into the hypopharynx, and then into the larynx, and then into the trachea, and then into the lungs. And this is a view straight from the nose. So the major things that are going to cause problems with eustachian tube function, either in an adult, is going to be anything that affects inflammation, mucus production, or physical obstruction of the eustachian tube. So if there's something like an adenoid, Pat, here, adenoids are the tonsils that are behind the nose. You may hear the term, we take out tonsils and adenoids very often in children. And that physically can cause a problem. And I have some pictures of that. A tumor in this area can cause a problem. Now in kids, as I was saying, is because their anatomy is poorly developed, the eustachian tube dysfunction in them is not nearly as concerning under normal circumstances. Now, most of the time, when an adult comes in with any form of eustachian tube dysfunction, I always put a telescope in their nose because I always want to make sure that there's not a tumor behind the eustachian tube in the nasopharynx, because obviously that would be the biggest concern. Now, most of the people watching here have their eustachian tube dysfunction because they're putting it under extreme circumstances, such as diving to great depths on a single breath of air. And that's sort of putting it under extreme circumstances, but that our body sort of has to adjust to that under normal circumstances, like me, for example, who doesn't free dive to great depths, doesn't have to deal with. So basically, any sort of fixed tumor there, a fixed adenoid, can cause pressure on the eustachian tube orifice here, or the opening, as well as any sort of inflammation that's going on in this region. Now, what can cause inflammation there? Obviously, infection of the nose, infection of the sinuses, allergies of the nose, because I like to think very often as the middle ear as well as the eustachian tube, again, as I said earlier, as a highly specialized sinus of the nose in a lot of ways. Now, obviously that's simplifying it a little bit, but as you can see, it comes right from the nasopharynx. Now we'll get to that picture in a little while, and we'll get to that picture in a little while. But this is what I was telling you about. So this is an adult who presented with eustachian tube dysfunction. Looking in the right nostril, you see the right eustachian tube orifice is pointing to that. And then in the nasopharynx, you see this big, ugly thing. That is, in all likelihood, a cancer. It would need to be biopsied and treated appropriately. So we talked about adenoid tissue. If you see on the picture on the top left, there's a normal, sort of relatively normal amount of adenoid tissue for an adult. Adenoids tend to shrink as we get older, but every once in a while, there's an adult that has very large adenoids that blocks the eustachian tube or doesn't have a lot of threshold for the eustachian tube to be disturbed, or the middle ear function to be disturbed, and doesn't let the eustachian tube function properly. Now, here's a picture of an adenoid, sort of right in the middle of this picture. And then if you look to the right is the eustachian tube orifice. This is a camera stuck through the right side of the nose. And if you see on the right side of the screen, that's the septum. I'm sorry, on your left side of the screen is the eustachian tube opening, and on the right side of the screen is the septum, and this is the right side of the nose. That's a picture of a normal middle ear. So here's some good anatomic pictures, and again, as you can see, and I keep sort of stressing this over and over again, if you and see if you can follow the
we can see
the sort of red spot. You can see the red spot. Okay, so here's the septum of the nose, and here's sort of a cartoon of air entering, and then there's the eustachian tube orifice there. Again, the muscles under that sort of are primarily open, this are called the torus tuberous and torus palatini. And when you swallow and yawn and try and do maneuvers, chew gum with your jaw, you're trying to open and stretch those muscles to open up the eustachian tube to allow air in. The other thing you're trying to do to force air in is often Valsalva. That's like when you pinch your nose and try and clear your ears, which is actually a technique that we tell people who are having eustachian tube dysfunction or middle ear disease, such as fluid in their middle ear, to do to try and clear it as part of our sort of non-medical treatment of it, in addition to medical treatment that we may use. As you see here, again, is the middle ear space that we're trying to regulate the pressure in, the eardrum next to it. Again, this represents the right ear. And as we go down, that's the eustachian tube there. Here, are you seeing that bar with like the list of options there in the screen?
No.
Of like spotlight? No. Okay, so you're just seeing the picture of the slide there. Excellent.
Yeah.
Okay, great. Okay, so again, here's what we call a coronal section of the nose. You see the sinuses all enter here. That's the maxillary sinus in the cheek. Above the eyebrows, the frontal, and above the eyes, the frontal sinus. That's the sphenoid sinus. I've actually operated on this quite a few times with Dr. Valdivia, biopsying and removing tumors from this region. It's an excellent pathway to go endoscopically through the nose, through the sphenoid sinus, to get to things on the bottom of the brain, then opening up from the top. And we have a lot of fun with that. I always look forward to our cases together with that, but as you can, but that's a discussion for another day, and probably isn't that interesting to a lot of you, just geeks like me and Dr. Valdivia. At any rate, so these are a cartoonish version of the ethmoid sinuses as well. Again, all of these sort of have to pass air into the nose, and any one of these that gets obstructed, we develop disease in there. It could be chronic infection, chronic inflammation. And again, when we develop inflammation in the eustachian tube, same situation, and we feel that as eustachian tube dysfunction. Now, some people feel that, often get that, again, at ground level, at normal pressure. And then some people, like freedivers, develop it because they're putting under extreme circumstances, and our body, probably without significant training in a lot of circumstances, isn't equipped to deal with that. So very often people come to see me to see how I can make them most ideal to deal with this. And the way I generally start off by recommending that whatever we can do to decongest and make the nose environment, in the sinus environment, as healthy as possible, we hope that the eustachian tube environment will follow and make it easier to accomplish your goals. But sometimes we do directly treat the eustachian tube with balloon sinuplasty, balloon eustachian tube plasty or dilation. And there's a lot of talk about that. We've been doing this for a number of years now after we sort of discovered that using balloon sinus dilation works to open up the openings there and make it decrease the amount of sinus infection, sinus problems, congestion, mucus production that people suffer, we sort of decided to let's sort of start researching on if we can do it on the middle ear space of the eustachian tube. And now it's sort of in practice very, very frequently. In fact, I think I've done a couple this month already. So it's not something I do as frequently as more of the more traditional sinus surgery and nose surgery, but it's something I do with some frequency for eustachian tube dysfunction.
Hey, Jonathan.
And there aren't, yes.
Question. So this is something,
Sure.
just to make sure we clarify to the audience. The audience is going to be free divers that do quite a number of equalization exercises a day, perhaps, or a week.
Yes.
And I believe from experience, at least most of the free divers have not been exposed to this sort of procedure, or have not seek this sort of procedure. And most of the equalization issues are not due to like anatomical variance of the eustachian tube, but it's mostly from lack of technique. But this procedure that you're referring to is mostly for
Yes.
people that have issues even on dry land. Is that correct? Not non-divers.
Yes, absolutely. There, in fact, there aren't that many studies out there with a large number of patients, of people who are scuba divers, because we're going to find much more information about scuba divers, let alone free divers in general for scientific studies of this type. But there aren't that many papers out there. In 2020, there was a very small paper, I believe out of Israel, that dealt with, I believe, 5 divers. A couple of them were military divers. Actually, I believe it was 4 divers, and they had to deal with 5 eustachians on them. And they actually got very positive results on them as far as patients complaining of symptoms. I actually have some notes on that right here, which I'm going to refer to because I just realized I don't want to go from memory. Yeah, so basically these were all adult males. 5 eustachian tubes underwent balloon tuboplasty for eustachian tube dysfunction during diving. The most common symptom, again, was the symptom that you're complaining about, was difficult in equalizing air pressure during descent. And again, some of these were military divers, so obviously they were very well trained. After the average postoperative period was a number of years, actually, and in approximately 3 of the 5 eustachian tubes that had measurable dysfunction, and basically we use pressure gauges to measure the dysfunction of the ear, as well as overall sort of questionnaires and stuff like that. That 3 out of the 5 eustachian tubes had basically normalized completely. However, the 2 that didn't normalize did improve. I haven't found a lot of literature out there pertaining strictly to the scuba diver or free diver who has normal eustachian tube dysfunction on dry land and normal anatomy that we can perceive. So obviously, I do think there is a role for this, as shown by this paper, because I have a feeling that they did this after they evaluated the patient and made sure that they had normal anatomy. The first thing I do is I try and evaluate their nasal condition. Do they feel they have nasal congestion? I really get them to concentrate on it, because a lot of people don't know what normal breathing actually feels like through the nose. They could be a chronic mouth breather and just think that's normal for them. They cannot realize until they think about it that, oh, they can't breathe through one side well or the other. And then I obviously do a very good physical exam. I looked at things like, is the septum straight? Or is this structure called the turbinus particularly swollen? I will also do an endoscopic exam and see, is there mucus drainage, purulent drainage, polyps coming out of their sinuses? I will also very often evaluate their sinuses with a CT scan, which I actually have in my office, and we can often do the exact same day to evaluate their sinuses. And then I almost always, again, try and treat medically before we start talking about procedures, if I think it's reasonable to do that. In these situations, I always try and experiment if they haven't tried things to see what makes them feel better when they dive. I have them experiment with Sudafed, maybe antihistamines like Claritin or Allegra or Zyrtec, or I have them spray Afrin beforehand, or maybe I'll put them on a short course of prednisone to see how that works. Prednisone is a very powerful steroid, which causes a lot of decreased inflammation and swelling kind of all over our body. But I'm hoping it works on the sinuses as well as the eustachian tube to decrease the inflammation there and get the lining to shrink down and make it easier for us to force air out there and equalize our pressure there. So these are all things I have to take into account. I will often use medicines like nasal sprays, like fluticasone, which is commonly known as Flonase, which is a nasal steroid again, which topically hopefully causes decreased inflammation in the nose and possibly actually gets down to the lining of the eustachian tube if it gets back far enough, and possibly can have some effect there. There's also a medicine called azolastine, which is a nasal antihistamine, which would have a topical anti-allergy effect as well. So I always try and treat conservatively. Always do an excellent examination and excellent history to see what factors are they not possibly thinking about or they haven't addressed that may help them get better, as well as make sure they're understand why they're doing their technique and what they're trying to do. And I always explain the anatomy to them very well. I have this poster you're looking at right now on every one of my walls in my exam room. So I can always explain to them what you're trying to do to equalize, and maybe somehow understanding the actual anatomy combined with their technique by instructors like Juan here will help them improve their ability to inflate their middle ear or increase the pressure there.
Hey, Jonathan.
Now, yes.
Question. Let's. I want to clarify. So what I encounter is that most of the, and this is not, by the way, a seminar for, again, how to teach people how to equalize. There's a ton of other guys that would definitely do a better job than myself at teaching you how to equalize. One of them.
I'm sure you do an excellent job.
I do all right, but I'm still having made, always equalization is perhaps one of the biggest obstacles in freediving, besides physical adaptability and mental preparation. But what the medications you mentioned, for example, Afrin, I've encountered that early on, if I used Afrin, it will give me tachycardia as a side effect, so I don't use it anymore.
That's absolutely possible.
Yeah, that one, and then fluticasone. That I do have significant rhinitis, like very allergic to dust and things, and fluticasone will help me. Astelline as well, the one that you mentioned.
Yes, Astelline. So I called it azolastine. Two names, just for everybody out there, they're the same thing, Astelline and azolastine.
Yeah, so it says antihistamine, right? Antihistaminic.
Yes, it's a nasal antihistamine. Yep.
And I had a question about vasomotor rhinitis, which is when I believe, correct me if I'm wrong, is when people have a lot of secretions nasally and nasopharynx upon contact with cold water or food. Do you encounter that? And what can you do for that?
Okay, so vasomotor rhinitis is an excellent question. So I would say for the most part, vasomotor rhinitis is doesn't tend to cause tons of swelling or nasal obstruction or edema of the airway. Not that it doesn't, but I would say not nearly as much as the typical allergic situation. What vasomotor rhinitis tends to cause is a significant amount of secretions. And they're usually sort of the watery, clear secretions. And I do notice that I do believe there are possibly some hormonal changes that happen as we get older, because we see it a lot more in older adults. I mean, more like, collecting Social Security age, where they feel like they always have to have a tissue on them because their nose will start running at any time. So we think of vasomotor rhinitis as sort of like a neurologic reflex. And that what happens is somehow a reflex arc is stimulated that causes increased secretions. And it could be, like you said, a reaction to cold water, meaning you're not allergic to the cold water, but it's just some neurological reflex that doesn't make that much sense, but it just doesn't. Some people have it when they drink alcohol. Some people have it during certain emotions. Sometimes people have it right when they start eating. There's really no rhyme or rhythm to what one person's stimulus is going to be. But yes, so treatments for vasomotor rhinitis. Again, we would normally start with, if they don't have a lot of nasal obstruction, I would probably start with something like azolastine, which, although is an antihistamine and is geared towards people who actually have allergic rhinitis, there is a drying effect of histamines, what we call an anticholinergic side effect, which decreases mucus secretions. If that's not satisfactory, I move to another medicine called ipratropium bromide, otherwise known as Ventolin, which is a medicine that was originally used in the lungs to help decrease secretions into the lungs. That worked actually quite well in the nose. The only issue is that it's you have to use it very frequently. I generally have patients start off who suffer from vasomotor rhinitis 2 times a day, and then go up to 4 times a day at the most, doing 2 sprays each nostril every single day. And we actually get very good responses from that. Now, there is a technique, actually a very simple technique that I did just a few hours ago on a patient who's suffering from vasomotor rhinitis, where we actually kind of stun what's called the sphenopalatine ganglion, and which is a nerve that runs right along this area along the arc of right where we leave the nose and enter the nasopharynx. Let me put my little pointer thing on.
Is that a branch of the trigeminal?
Well, yes, it is. It's a branch of the trigeminal. And what it does is it gives nerve it gives nerve and innervation. I'm sorry. Thank you. Innervation to the sort of posterior nose. Actually, the sinuses, the septum, and a lot of the posterior nose as well. And what happens is, just like in sort of chronic pain, where you're trying to create a nerve that goes basically a little bit numb, you'll often do radio frequency or freeze that nerve. Sometimes neurosurgeons will do it, or neurointerventional radiologists or pain specialists. Well, I do the same thing to this nerve. Obviously, it's not the first thing I do, like I said before, where I actually endoscopically go in with a device, and I actually can freeze it. I do about a 30-second freeze along the course of that nerve, and then actually it's a balloon that fills up with liquid nitrogen, very, very cold. I let the gas run into the balloon, and then I turn it off after 30 seconds. And then I wait about 45 seconds for the balloon to sort of defrost, because if I just pull it out, it'll tear a whole bunch of the lining, and that would kind of be a bloody mess to have to deal with. So we wait 45 seconds, and then I remove it, and then I do the other side. And we have some very, very good results with that. Now, I also do the same procedure with radio frequency ablation. That's almost an identical procedure. We do some with freezing and some with radio frequency. Sometimes I let the patients decide based on their research. I actually feel that they're both comparable procedures to help vasomotor rhinitis. And those are called commercially, they're marketed, and one is called the Rynair procedure, and the other one is called the Clarifix procedure. And
Hey, Jonathan,
yes,
question, are you able to see the chat window? There's a question there for you.
I can't see the chat window. What do I press to turn that on?
I can read it for you. You can just go to you can just exit
Sure.
full screen.
Yeah, I definitely want this to be interactive. I'm sorry, what was the question?
So this is, it says, I got diagnosed with Eustaquian 2 dysfunction and barotrauma and otitis on the right ear in late 2020, treated with steroids and nasal sprays. This didn't help me. I don't have issues equalizing now, but I have a constant clogged feeling on land, and that feeling has never gone away. What would be the next step? Be surgery? Question mark. What kind of surgery is to correct Eustaquian tube dysfunction? What kind of surgeries? Yeah.
I'm sorry. So, okay, so here is, unfortunately, with just that little bit of information, it's a little bit sort of difficult for me to give you sort of a direct answer. So, but basically, if you have a constant full feeling in the ear after you're having barotrauma and I believe you said otitis, and it was treated with steroids and Eustachian 2 and nasal sprays. Now, is this a free? Did this happen while free diving?
This is just Cyrus' question. Would you mind?
Yes. Hi. Yeah. Hi, Dr.
Yes.
Forman. Yes.
Hello. Yes.
The incident did happen while freediving. Yes.
Okay. And then you were treated, and eventually you got better. And I'm imagining you're freediving now, and you're able to equalize now as you freedive.
Yeah, I have no issues equalizing. It's just that constant clog feeling on my right ear. I was not able to finish the steroids. I was having some strange adverse reactions to it, so I just stuck with the nasal sprays. But
sure, well, that's certainly an issue. A lot of people do have issues with prednisone, and I often, I always warn them about it because I think that sort of being prepared and expecting it sort of helps you tolerate it if you're going to have these adverse reactions. But sometimes there's some people who just can't finish the course of steroids, unfortunately. It's a minority of the patients, but it's a significant minority of the patients. So basically what I would need to do, the first thing I would start off, obviously, is, like I said, is a physical examination, but I would also get a full audiological battery of tests, which you probably had at the time when you saw your doctor. Where we do a hearing test, we do a tuning fork test to see if your bone conduction is better on one ear than the other, which is a sign of Eustachian tube dysfunction or neurological hearing loss, depending on if it happens on the ear you're having trouble hearing on or not. Whether you're not hearing, whether you hear the tuning fork louder on the side you are not hearing well on, or the side you're hearing better on. But and it's sort of it'd be difficult to get into sort of the explanation of that right now. But also, so the audiological testing would include a hearing test. It would include your speech discrimination. It would also include the pressure behind your ear at regular sea level. So I'm assuming you still have this fullness all the time at sea level is what you're talking about, not while diving?
While diving, I don't notice it if I'm in the water, but I do when I'm on land.
Oh, you do? Okay. Yeah. Are you able to equalize on land for at least a few minutes and make it feel equal to the left ear? Or not, you can't do that at all?
I hear it pop, but it's never felt clear compared to the one that's fine.
Okay. So obviously I would do a really good examination. I would scope you. I'd possibly get a CT scan of your sinuses. I would also do a very good examination of your temporal mandibular joint, see what it feels like when you open and close, because the temporal mandibular joint is the joint between our mandible and our skull base. And the skull, part of our skull where it attaches is the temporal bone, which is actually the ear, the bone that contains all our ear structures in our skull. And so obviously a really good examination would be where I would start with that. Now, suppose, let's say we had a completely normal exam. Your sinuses were completely normal. Your anatomy was completely normal. You didn't have an adenoid problem. You didn't have a tumor problem. And your Herring test was completely normal. And your TMJ joint did not seem to be inflamed. I would go over a list of all the medicines you've done. It sounds like you did nasal sprays, you did steroids. I might do a little bit of experimentation again with Afrin if you don't have any adverse reactions to that for a period of time to see if that helps. I might switch to different nasal spray, but eventually if we tried everything and nothing worked, then I would offer you the eustachian tube dilation to help you feel better. And that would be the surgery I would offer you. Now, somebody who's driven absolutely crazy by this, I might offer them a myringotomy, which is where we put a tube in the ear, because that'll directly equalize the pressure and take the, so here's a normal eardrum. This is the right ear. And here is actually the left ear, not the same patient, but another picture of a left ear with a tube in it that helps equalize the pressure directly between the middle ear and the world. So I wouldn't offer you this because this would make it basically impossible for you to free drive. And since that's your recreation that you seem to enjoy most, the fact that you're on this is I wouldn't want to offer this to you and take that away from you, because the risk of at that depth with the pressure of water getting past even waterproof earplugs and a swim cap and everything, it's too risky to have water rush in there through that tube, get into your middle ear, cause a lot of disorientation and possibly have a tragic event. So again, I would offer you the eustachian tube dilation, which I do endoscopically through the nose while you're awake. Takes me approximately 2 minutes to do once I have you all prepped under local anesthesia. And this is do you see this picture here? Does everybody see this picture here?
Yes.
Juan?
So
Okay,
this is
great.
the dilation of the right eustachian tube, huh?
Exactly. So again, we are, okay, so this is the back of the nasopharynx here. This is when you're a kid. You see what I'm circling here? That's where your adenoid pad is. So you have adenoids that when you're big are quite large sometimes, and they actually push on the eustachian tube. So that's in a kid, sometimes as an adult. If you were an adult and you came to this problem and you had a very large adenoid pad, I'd recommend let's take out your adenoids and see if it indirectly helps your eustachian tubes get better rather than directly disturbing the eustachian tube. This is your soft palate here. In this, so we have slid through the nose. This is the nasopharynx. These are structures of the nasopharynx. On the bottom is the soft palate, but not the part that you see when you open your mouth and say, ah. It's the part on top of that. That sort of, it continues with the nose. If air goes down here, again, goes down into your larynx through there. And sometimes, like if you start laughing when there's milk in your mouth, this will relax, milk will come through and you'll sort of spit it out your nose. And it's hilarious for everybody but you. This is the eustachian tube orifice on the right side. Endoscopically, I've put this angled catheter into the eustachian tube. I inflate it up to about 12 atmospheres. So just in case you don't know what an atmosphere is, our normal pressure at sea level is 1 atmosphere. So 12 times normal pressure this balloon gets filled with and stretches the cartilaginous part of the eustachian tube. And we leave it in there for 2 minutes. And then we take it out and we hope that it does its job. I'm think I may have a okay, great. Here's another picture of sort of the theory of what happens. So you have the balloon. You have the balloon here in the cartilaginous part of the eustachian tube. Okay, and then you have the bony part, and so this connection here is called the isthmus. That we are going until we feel a hard stop, because we only want to dilate the cartilaginous portion of the eustachian tube. We dilate it. We may get a little bit of stretch on the cartilage that may stay, but the big thing that it's working on is what we call the mucosa, which is the lining of the inside. So here you have the cartilage, and here you have the mucosa lining it, and then you have the lumen. The lumen is actually the part that you force air through, kind of the opening of it, like the middle of a straw that you suck water through. We call that the lumen in medicine. You inflate the balloon, and the theory is that it forces all the lymphatic fluid and lymphocytes back into our vascular system. Edema is basically movement of fluid. That's basically swelling, edema, movement of fluid into the lining of any sort of space in the body. And the way we get rid of edema or swelling is by having that fluid and the lymphocytes responsible for it get resorbed into our vascular system. So according to this, the theory is that it sort of forces it back into that, leaving you an open, dilated eustachian tube. Now, that is one theory. I also have another thought process about this that might not be as popular, that I actually think it may cause death to the lining of the eustachian tube in this region. And over time, that pressure causes death of the lining to some extent and causes it to slough off, basically. And that you don't really notice happen. But then when the lining of the eustachian tube reforms, it forms with a nice, new, healthy lining that's no longer swollen. And again, we hope over time that helps. Now, sometimes, we get responses where patients feel better a few months later. I would say if after 2 months, 6 weeks, they don't have any response, they're probably not going to have much of a response much. But occasionally, I have a patient who feels better by the time they get home from the procedure that day, and it just keeps feeling better continuously. Again, that's a great question. So I see somebody named Sarah. So that just popped up. Ask the question, how long does this last? In some patients, it could last possibly forever. In some patients who are highly reactive, it may need to be repeated, in a number of years. I believe I've only repeated it once. Now, obviously, there's going to be some patients who are lost to follow-up, some patients who it didn't work for, and they don't want to try it again, even though they may have thought it worked. Or just don't want to go through the ordeal again. But the long-term data is quite good, but again, it's not perfect. I can't really quote you any percentages as far as how long it will last. I see another question that I can't read the whole entire question. Can somebody read that to me?
Yeah, so it says,
it was from Anna, I believe.
Yeah, what kind of preventative care can I do to keep my eustachian tubes healthy? Is diet important?
Okay. That's a very good question. And I would say, obviously, if anything you may be allergic to, stay away from, because that's going to cause inflammation of the upper airway. Other than that, there are some theories about people responding to dairy products causing increased inflammation of their nasal sinus, nasopharyngeal, upper airway, basically everything the ear, nose, and throat doctor sort of works with, causing some increased inflammation, mucus production, and possible edema. Even though that's very popular out there, I would say that it's very specific for each patient. So I would say that's kind of going to be a trial and error thing on each person. I definitely would not, if you're doing well, I would actually say just ride it out until you're not doing well. I wouldn't necessarily do much preventive treatment unless you are having issues, I would say the most preventive treatment you can have is if you do have chronic nasal congestion, to try and deal with it one way or another. And that could be just using Flonase on a daily basis. That could be taking an antihistamine. That could be taking Sudafed. I don't mind anything.
Do you mind if I add something? So to keep the
Sure.
ET tubes healthy, I mean, I'm not definitely, I don't do your specialty, but from personal experience, I'm pretty allergic to milk in regards to that. Even to
Yes.
soy milk or oat milk, I still feel a difference after doing a couple tests to in regards to how sticky is to equalize. You can test the opening pressure to equalization with the EQ tool from Italy that from the UBA company that sells this EQ tool. There's actually a tool, Jonathan, that you can put on your nose. I'll show you sometime, and you can measure how the pressures on kilopascals to open your ET tube.
That's really interesting. I'd love to see that.
No, I'll show you. And if the pressure, it's a little higher if I drink even oat milk. And another thing is air conditioning. AC is, for me at least, is horrible. I cannot use it if I'm diving, and I go to even great lengths as sleeping with my socks on, no AC, or even using a hoodie without the AC to keep my ET tubes from being sticky.
Wow.
That's how much how much I care about it. So I don't know. It's just so individual, so personal.
Sure. So I do want to sort of bring up one thing that I'm not such a big believer in, to be honest, but it is out there. So I think I should share it with you. And that's called eustachian tube massage. I don't know if any of you are familiar with that. And you're all able to see me, correct?
Yeah.
Right?
Yeah.
Even though I can't see all of you. Okay. So if you sort of go behind the jaw, sort of in that little cleft, you'll feel it kind of behind what we call the radius of your mandible. You'll feel that little sort of bony area kind of behind the between sort of the mastoid region of our ear and there. And then if you kind of put two fingers there and sort of massage kind of all the way down to your collarbone, theoretically, it can help open up your eustachian tube. Now, I think it's kind of more theoretical. Some patients and some people do say it works. I'm not sure if it's more of a placebo effect or not, that they feel it's working. I will say this, is that it's very important, I feel, and I'm sure you guys are doing this since you guys are the experts in this, is to start equalizing early. Don't wait till it becomes sort of overwhelming to equalize, because we want to, once the eustachian tube is 100% collapsed as we descend and we get pressure, it's going to be harder to open up. So we want to continuously try and blow that open to make it easier to equalize the middle ear, rather than overcoming, a lot of resistance all at once. It's better to do it in little steps as you're getting further down.
Yeah, agreed. Again, we're not gonna touch on how to equalize, but two words that I learned that I'm still trying to master: relaxation and awareness. So once I'm able to be aware of the position of the posterior tongue and the palate and the torus tubaris and this and the salpingopharyngeus muscle, etc., palatal-glossus, then yes, obviously it will be easier, but that takes time. Takes time and practice. And Biso is an amazing physician from California that is asking you a question. I don't know if we'll be able to answer this one because it's perhaps technical, but so it says, what do you think about Eustachian tube flexibility exercises? This is taught by a very amazing freediving instructor, Adam Stern. So it's basically which 10 daily repeats of a series of 5 progressively more intense equalizations, holding pressure for at least 10 seconds. Yeah, I'm not sure if I can speak to that. I'm promising. I'll probably say an answer that is probably wrong to that. So I don't know if you can answer that, Jono.
So I've actually never heard of that, but is that where you're trying to equalize on dry land and hold pressure multiple times a day? Is that what
Yes,
you were?
this is sort of
Okay.
collective knowledge of the freediving community that it's passed on and it works. But
Okay.
yeah.
I actually don't think that's a bad idea. I mean, I would want to read through the technique, but I think the idea of trying to sort of stretch out your eustachian tube, force air up into there, is a lot of the same concept as we do with the balloon. Just obviously the balloon is a lot shorter period of time. We put it in there for about 2 minutes and inflate it to a very large amount, trying to force edema, again, the swelling of the lining out of it, as well as sort of maybe stretch the cartilage a little bit. I think you're just doing the same thing, kind of just doing it in very small increments over and over and over again for longer periods of time. Now, obviously, I don't have a scientific journal article to back me up, but it certainly sounds reasonable to me. And I think sort of it's one of those things where the proof is in the pudding. If it is working for you, I think go ahead and do it. It certainly doesn't sound dangerous. But I can give you sort of a corollary is that when I have patients, just, a regular patient who comes in with otitis media, which is fluid behind the eardrum that they developed for some reason, again, let's say an adult on dry land, maybe they had a cold and then they develop fluid in there. The cold is gone, but the eustachian tube is still inflamed and the fluid hasn't passed. I may give them everything we talked about: steroids, decongestants, nasal sprays. But I will also tell them that they should do exactly kind of what you're describing, do the Valsalva movement, try and auto-inflate into that ear. I tell them to do it at least 10 times a day, even more if they can. I said, do it. Unless it starts to hurt, don't stop doing it. Just keep equalizing. If it gets uncomfortable, stop. And sometimes it'll work and sometimes it won't work. And I tell them to keep on doing it. But I think over time, it does sort of help to inflate the eustachian tube and cause and force air up into the eustachian tube, allow positive pressure or at least equal pressure there, and the fluid to evaporate away. Again, it's not exactly what you're talking about, but it's a similar idea.
Hey, John, one more question from Dr.
As
Phil
many as you
Montoya.
want. Sure.
Sarah's a physician in Florida as well, and she's asking about the risks and or contraindications to eustachian tube dilation.
Okay, so obviously I wouldn't do it on anybody who, the typical sort of all the issues, somebody with cardiac issues, somebody with a bleeding issue, somebody
Your general
with
contraindications for surgery.
General contraindications for surgery or procedures. I would say a contraindication would be somebody who hasn't been managed medically, hasn't had an excellent examination, has not had a hearing test. Every single person who gets this, in my opinion, needs an audiogram, and it should not be done without an audiogram, because that's an important thing to document sort of the status of it before, and also see if there's any other causes for it. I would say, we would want to evaluate, not necessarily be a contraindication for any TMJ issues that may need to be evaluated. I would definitely want to make sure, again, like we said, that we've dealt with any of the nasal issues as much as possible, any tumors in the region there. But the fortunate thing about this is that it is relatively well tolerated. It is very minimal risk. I would say, so there's very few people who aren't good candidates for this, as long as the workup has been done correctly. I would not do it. If you have, let's say you on your examination, you have some very awkward appearing eustachian tube anatomy, I wouldn't just go ahead and dilate it without doing a CAT scan of the temporal bone first to see if there's any reason why the anatomy looks abnormal when you do a physical exam of the eustachian tube.
Gotcha. One question Jonathan. So in free diving, using ibuprofen or NSAIDs is not uncommon to not only decrease inflammation of sinuses, mucosa, Eustachian tube, muscle, joints, etc. But then there's always a risk of sinus sinus barotrauma or
Yes.
tracheal barotrauma. Are you always concerned about the risks of overbleeding or increasing your bleeding time with ibuprofen? I am, from a surgery standpoint, like if I will do an elective surgery on anyone for anything, if somebody took ibuprofen in the last 5 days, I would rather not. I would postpone that. So I've always have this in my mind, like if I take ibuprofen for anything, even 200 milligrams, and I go diving, there's always a risk that if I had a bleeding from a sinus, it will become a bigger bleeding. Would you agree with that or no?
I would absolutely agree with that. Ibuprofen, and so for people who don't know, ibuprofen is a member of a class of anti-inflammatory drugs, which are called non-steroidal anti-inflammatory drugs, or NSAIDs for short, if you've ever heard that term. I'm sure most of you have, but some of you might not. And that includes aspirin, ibuprofen, Aleve as an example. Tylenol is not an example of that. Tylenol is a pain medicine and an anti-fever medicine, but it's not an anti-inflammatory medicine.
Correct.
But I just want to make sure people know what I'm talking about, but what we're talking about. But ibuprofen and the other NSAIDs, what they do is they decrease our platelet function, which makes it difficult for our blood to clot. So potentially, again, in surgery, I have all my patients stop their non-steroidals. Aspirin, I try and stop it about 10 days beforehand. Ibuprofen, I recommend that they stop it about 10 days beforehand as well. I also ask them to stop any supplements they may be taking, fish oil, multivitamins and stuff about 10 days beforehand, because we never know what ingredients in there are going to work against us sort of clotting, and we never know what other things are in these sort of over-the-counter products that are marketed that that may increase our bleeding issues during surgery or during a dive. Now, the thing is that if a blood vessel burst, at those great depths due to pressure changes or some sort of trauma, yes, obviously there is some increased risk, I believe, of having worse bleeding in the sinus or your nose or your middle ear space, or like you were talking about during tracheal squeeze, occasionally you'll cough up some blood afterwards. Mm-hmm. So that is a very good thought. I actually wasn't aware that divers were taking so much ibuprofen and stuff during diving, but yes, it's definitely a risk taking ibuprofen. Now, it's not exactly as bad as, let's say, taking heparin or Eliquis, and these are all sort of drugs we take to really thin the blood out for people who have a history of strokes, heart disease,
that's really
vascular
dangerous.
disease. Yes, I would not recommend, actually, if you do that, doing this or anything that's potentially traumatic, like playing rugby or something like that. Because I think Juan and I have all seen, probably together on the same patients, people who've had horrific issues where they just have fallen down and they're on these blood thinners, and it causes a brain bleed and other issues and stuff like that.
I think the message is to just be careful when pushing limits on depth and while taking anti-inflammatories or vitamin E, other supplements that can increase your bleeding time, because a little bleeding from any respiratory trauma can turn into a bigger clinical issue.
Exactly.
That can compromise your airway. And 100% absolutely agree with you with other stronger anticoagulants like Eliquis and Xarelto and those things. I'm sorry to say brand names, but they have good use for some things, but
they're great drugs for the right reason, but
Yeah.
Every, it's sort of a double-edged blade there.
Right.
What I was going to say is, so the one exception as far as vitamin supplements that actually could have the opposite effect and actually make our blood easier to clot would be vitamin K. Now, a lot of us are not taking vitamin K alone as a supplement. It's a fat-soluble vitamin that we take sometimes, and sometimes people do have deficiencies of it. But I would say, don't sort of separate out your vitamin K and take it before, just say, oh, this is okay. I would just stop all supplements, because you never know what's going on in these factories that are not as regulated as much as true pharmaceutical factories, as far as what's ending up in the bottle and the pill before surgery or before anything that's potentially traumatic.
Yeah. Well, let's see if there's more questions.
Yeah, sure.
So let's see. So we spoke about that, and what is? I have a question from someone here. What is the average time for healing, or the range of time for healing from a ruptured eardrum or perforated eardrum during diving, for example? Then I've seen. Go ahead.
I'm sorry.
No, you go ahead.
That's an excellent question, and I would say it's quite rapid most of the time. I would say it's usually within 3 to 4 weeks on average. Of course, there's always exceptions, and it could take much longer than that. It could even need a surgical repair if it doesn't fix. I would say on average, it's in about that 3 to 4 week range from sort of a traumatic rupture from barotrauma, either from like an infection that causes it, or fluid that causes it to perforate, or a perforation while freediving. Now, there's going to be a lot of factors at play in this. First of all, there's a very good chance you'll develop an infection that needs to be treated with a combination of PO, meaning antibiotics by mouth potentially, and eardrops to try and clear the infection out if that does happen, because what's going to happen is water is going to rush into your middle ear, and potentially cause an infection as well through that perforation. But generally, I see most of them heal. In my experience, again, this isn't sort of statistical averages that I've taken from a textbook or from within 3 and 4 weeks. Now, I did have a high school diver who developed a perforation in his left ear, and it was clear as day. He had hearing loss. I saw him a week later, and it was completely healed like it had never happened. And it was quite a sizable perforation. And I was very impressed by that. That was a little sooner than normal. But I'd say on average about 3 to 4 weeks, if, stay away from water. Don't try and keep equalizing, because now what you're doing is you're forcing air through that hole and not allowing it necessarily to heal as fast.
Mm-hmm. Okay. Interesting. So, and when to at what time, if it hasn't healed, one should be discussing other options with their ENT surgeon, like surgery to patch to close it, or
absolutely. So you're probably not going to want to hear this, but I would probably wait a solid 6 months before I do a procedure to patch that or fix that, because most traumatic perforations will heal on their own, and sometimes it just takes some time. So I would probably give it a good 6 months before I would subject somebody to the risks of a procedure. 6
months. Oh, that's a long
that's
time
what
to
I
be
would
of-
think.
No, that's fine.
I know. I know. Yeah, it's a while.
I'm going to try to copy and paste your information again to everyone,
Sure.
so that we can share, but I can't for some reason. That's difficult. So your office is 813-877-3100. just so that everyone can reach out to you if needed.
Yes.
Um,
So that's
Right.
my office number. If anybody is in the area and wants to come in and see me for any problems, I do take a lot. I take care. Besides having a general ENT practice, I take care of all sorts of ENT issues. But I do, thanks to Juan and including Juan, have quite a few numbers of free divers. I also just want to say that this is my medical office, where everybody calls to make appointments and call in consults and stuff like that. So I'm not going to be able to necessarily, call in with a question, sort of, say, hey, I saw you on this broadcast. Can you answer this question? Can you answer that question? I apologize in advance. It's just we're not equipped to do that because it's going to be my staff who answers the phone anyways. Now on the email, feel free to email me any questions you may have. However, I just want to apologize in advance if I don't get to it in a timely manner, or maybe actually miss it, because as you can imagine, I get many emails and I'm always way behind in answering them. And I'll probably be answering them on the, 5 minutes before I die. Still trying to get caught up in answering emails. So again, I apologize in advance. I'm always behind in answering emails and texts and all sorts of stuff like that. So I'll do my best.
Thank you so much, Jonathan. This has been very
Sure,
educational.
of course. Absolutely. I hope you all enjoyed it. I hope it wasn't too boring and involved, but I really do enjoy this.
Oh, it was great. And I think the message is in freediving community, equalization is the big obstacle for everyone, including myself. I think it's my biggest thing. And if you want to learn from someone like an expert, look at other people to really learn proper techniques and daily exercises. And for what I understand, it's not the anatomy that is the issue in freediving, but it's the technique, which takes a lot of practice and a lot of time. But when there's anatomical issues, then yes, someone like Dr. Forman will be able to help you. And this has been great, Jonathan. Thank you so much for doing this. And
sure. Absolutely. Yes. Yes. And again, like Juan was saying, is again, I don't free dive, but I do feel that technique is probably the most important thing. Always working on your technique, improving your technique, and adjusting technique. And I know that in everything I do, whether it's snow skiing or doing surgery, technique is how we overcome most difficulties. Again, sometimes like that training that I think it was a doctor from California who's asking about it. Might be the way to go. But again, I'm always there to evaluate if somebody can come to my office is having problems, why they may be not able to overcome their issues. But thank you very much.
Thank you, Jonathan. We'll see you soon. And thank you, Lisa, Sarah, and everyone. We'll see you next week. Cheers.
Absolutely. Thank you. Bye-bye, everybody.
Bye, thank you.